Kudos to Humana and Athena. They've been two great partners to work with for the last few years. Data's good, APIs, so thank you for all the hard work you do. My name is Jerry Shultz. I'm the president of Lightbeam Health Systems. With me is Peter Brawer, who's with Healthcare Highways. First, I want to thank all the team from KLAS for putting these events on. You give us an opportunity to speak with a single voice, and you write some really important position papers to Washington and are doing a lot of important work, so thank you. We wouldn't have this kind of, I think, focus if it wasn't for what you're doing. I did participate in the 2019 event, and the number one thing came out of it was a lack of alignment between payer providers. COVID put us on pause, but here we are focusing just on this topic. Lightbeam's mission is to help payers and providers thrive in value-based care. The mission's too important to fail. We know about the spending, we know about the lack of quality or the quality compared to other countries, we know about health equity, we know social determinants are drivers, but we're having trouble moving the needle. And we have to, the work is too important to fail. My friends here at Healthcare Highways are doing really important work along with Dr. Preston out here. She actually does the work that Peter and I talk about doing. We hand it over to Becky to make it real, but I'm going to turn it over to Peter to tell you how the first part of this partnership and what's moving the needle focuses on identifying and managing high-risk and rising-risk patients. Peter?
Thanks, Jerry. And I do want to say a thank you to Boyd also. So my guess is that I'm the only clinical psychologist in the room. I saw patients for the first 15 years of my career, got a little burnt out at the end of it, but for Boyd to be vulnerable and transparent and to put a face with a name and make mental health real, talking about people who can really make a difference. So Boyd, thank you. Thank you for talking about something very dear to me. So real quickly about Healthcare Highways. Healthcare Highways is a health plan. We operate in 3 states, Texas, Oklahoma, and Louisiana. We have our own PBM, our own care management company that Dr. Becky Preston is the CEO of, our own repricing agency. But we have talked so much about collaboration so far today between payers and providers. We actually take that word collaboration and move it 1 point forward and really talk about partnerships. When we go into a marketplace, we partner a 50-50 joint venture with a provider in that space. What we allow them to do then is to really insert competition into that marketplace and allow them to really transform what's going on. So in our earliest true partnership was with Baton Rouge General. Baton Rouge General is a smaller hospital health system, obviously in Baton Rouge. They're surrounded by Our Lady of the Lake, good hospital, but a larger part of a larger health system. We have our friends, Ochsner in Louisiana, who are very, very large, and they didn't have a possibility really for growth. By allowing us to create this high-performing network in the state of Louisiana, it changed their footprint. They became a very kind of niche player and became actually, Verity is our joint venture, they became a statewide play where all 4 Medicaid MCOs use the Verity network exclusively. So interestingly, about 3 or 4 years ago, we started going down into value-based contracts and realized that there was a number of problems. And trying to identify those high-risk patients, it was highly manualized. As a scientist myself, it was intuitive, it wasn't scientific. It was inefficient. There was too much data and not enough information. Nurses not working at the top of their license. So we really went out and looked at who could we partner with. That's how we met Jerry. That's how we met Lightbeam. And we wanted to increase our efficiency, increase our accuracy, and really be able to identify those high-risk, high-cost members that we can make a difference at. If we go to the next slide. And so this is really, for someone that's been in the population health risk management space for pushing 15 years, this is the clearest dashboard I have ever seen. So Jerry, do you want to talk through this?
Thank you, Peter. I'm not going to share the dashboard, but just make a point about it. There's 2 keys. We talk a lot about, in fact, Humana and Athena just talked about making it simple for the physician. There's really 2 keys, and we talked a lot yesterday and today about technology, but it has to be ubiquitous, right? It can't be an extra step. Physicians are already overloaded with too much information, so we've got to bring to them, like we do with our friends John at Holon. We've deployed in many large CINs that have 40, 50 different unique EMRs, where we let physicians see not only the care gaps, but social determinants. They can't drive, they have housing pressure. They've had 3 avoidable ERs in the last 12 months. Information that they're not gonna see within their EMR, and make it easy and make it simple. And we do the same thing for the care managers at Healthcare Highways. We show them the top 3 or 4 things that they need to focus on. But then we also take a broader view, taking a step back, and show the physician very quickly and easily how they're doing in each value-based care arrangement. And remember, some of our clients, some doctors have 5, 15, 20 different value-based care arrangements. They see 50, 60 patients a day. You're talking about 10 different benchmarks, 10 different sets of quality measures, 10 different sets of everything. You've got to take that complexity and make it simple. So we let them see exactly how they're tracking. Are they are they tracking to generate savings? What's their panel size? How far are they from the next target? We've all heard stories of the doctor who walked into the CEO's office, first year in value-based care, got a $50,000 bonus. Second year, went out and bought a pool or put money down for a boat, no bonus, was furious. Had no idea between year 1 and year 2 how they were tracking. Think of it like a basketball game where there's Steph Curry sinking threes, or was that a 2? The game ends, and now we tell you what the score was. And that's been one of the barriers, I think, for physician adoption. If you reveal this, you make it easier for Becky and Peter to show them, we're going to add these costs for care management and for technology, but these costs are offset by these savings. This is the bigger, broader picture of how we can move the needle and improve health and quality and outcomes.
And I was just going to add on, and I love Jerry's analogy of showing the scoreboard at the end of the game. But as someone who's run care management in other organizations, I'm going to do it a little bit differently, Jerry. I'm going to talk about that there's a scoreboard actually running the whole time, except it has 2,000 metrics on it. And the score is this tiny little piece, right? And what Lightbeam actually allows you to do is get to those actionable pieces of information instead of slogging through data. Really, our care managers at Healthcare Highways and High Care really notice that that level of efficiency changes what they're able to do.
And this is what really matters, guys. It's making an impact. It's saving lives. It's keeping people out of hospitals. A 13% reduction in something are people. We recently identified a patient who was homeless, did not speak English, was in Detroit, Michigan, was hardworking, trying to get on his feet. This was actually Spectrum, but Healthcare Highways is doing the same work with this case study that's going to come out. They, using social determinants of health combined with the other factors, did an outreach program, found a what do you call it, where you go at night, a shelter that would allow him to go in at midnight, after midnight. 6 months later, he's now getting his own apartment, has not been back to the emergency room since, had previously been in the emergency room with pneumonia 3 times. This is what it's about. It's affecting one person's life like that, and that's the kind of work Becky's team does every day, is keeping one person out of the hospital, letting them walk down the aisle, see their granddaughter, walk their daughter down the aisle, and that kind of thing, and saving a lot of money in the process.
And the last piece I'll add to that, Jerry, is when you have a health system, and all of you, the provider groups here, know that there's always choice. And anytime I speak with a CEO, there's a handful of top 3 levers. Out of network leakage, I know that's a horrible word, people don't like that word, but leakage is a huge thing. By allowing our care managers to identify those patients that might have gone to Our Lady, that might have gone across the state to Baton Rouge, and to get them and to keep them within network and allow Baton Rouge to keep that market space and actually grow it. That's another part of this equation that we usually don't talk about. So you have 2 guys from Jersey that everyone else did all their 10 minutes. We spoke so quickly, we have about 2 minutes left for questions. So go Jersey, and we'll take those questions. What exit?
The shore.
The shore.
Down the shore.
Yeah.
Texas now, actually.
Yeah.
It can be accessed by the provider from the EMR, but it's populated in conjunction by working with a payer to take the back-end benefits that Healthcare Highways associates to that provider. So we build the rules in so the provider sees where they're tracking, and Healthcare Highways knows how they're tracking. It's either by logging into the portal or by putting a single sign-on link from like, Athena or something to that. There's two different ways of engaging the provider. One is a ribbon or actually API direct into the EHR, Smart on Fire. And then the second is a dashboard. It's basically a broad view of the whole picture, or now I'm with a patient and what's most important, which is the same thing we do for Becky's care team. If a patient is admitted to the hospital and 4 chronic conditions, 20 factors each, we try to boil it down to 3 or 4 things that Becky's team really needs to understand are really important about this patient. Husband just died, children live 8 hours away, doesn't have a we pull 4,500 data points through our AI engine and identify a lot of social determinants to help you really focus on the right things. So we try to share the same views between the care teams and the providers, and let also the provider know in that ribbon, like John's ribbon, for example, that this patient is in a is in a cohort and being managed by Becky's team. So they see there's a coordination of care between the PCP and the care managers, and across the network, as Peter just said. Yes, sir. Great questions. More engaging, a lot more around health equity, social determinants. You see the ACO REACH programs, which we have several customers who are involved in that, are pushing to move those metrics to the forefront. Jeannie and I were talking earlier about RPA, robotic process automation, taking the data that we've identified, rather than, if Becky's team identifies that a patient needs a mammogram, why just load that up into the EHR, assign it to the PCP, and automate a lot of those manual processes? Great question, though.
When we all started, there was almost a one-to-one care manager to patient. We know that those ratios are no longer stable and they're no longer sustainable. And with the workforce shortage that all healthcare is going into right now, the more efficient, the more things we can do in an automated fashion, and I didn't highlight that enough on my slide, right? The more automation that we can bring in partnership with Lightbeam and Lightbeam-like companies and really reserve that staffing, that's, I think, where the huge next step is.
That is a key immediate step, care manager empowerment. We all know the stats that from now to 2030, there's going to be a nursing shortage, and some people are saying beyond that. Care model redesign is a consistent theme across all of our customers this year. If you ask them what one of their big goals is, it's care model redesign. How can care managers manage 1,000 patients or 1,500 patients as opposed to what they manage today? Technology has to play a role in that, obviously.
Thank you very much.
Thanks.